Hello and welcome to my channel. This is a new course that I'm starting called the MBBS FlashDash, which is mainly aimed at final year medical students who need a quick revision before their finals. In this video, I will be continuing part 2 of the cardiovascular series. Do check out the links below in the description if you want written notes from my website and also flashcards, which I will be uploading on Pinterest. So let's get started. In this video, we will be covering congestive heart failure, pulmonary edema, dilated cardiomyopathy, infective endocarditis, dissecting aneurysm, aortic dissection, ruptured abdominal aortic aneurysm, AAA, postural hypotension or orthostatic hypotension, and also falls. Okay, the first one, congestive heart failure. So the patient may present with ankle edema or PND. PND stands for paroxysmal nocturnal dyspnea. So basically, when you take a history of the patient, you want to ask, how many pillows do you usually use to sleep? That's because, some patients may normally sleep with 2 or 3 pillows for many years. And then you ask, is it normal, for you to be sleeping with 2 or 3 pillows, and is there any increment recently? Maybe now you sleep with 4 or 5, or maybe they even sleep with 1, or they don't use a pillow, but now they suddenly have to use, and they suddenly have to use 2. Apart from that, you can also ask, did you wake up because you couldn't breathe? Other presentations, they may have shortness of breath, of course, raised JVP, pleural effusion, and also cardiomegaly. So if you were to do a chest x-ray, you would notice an increased cardiothoracic ratio. So a normal cardiothoracic ratio is about 0.42 to 0.5, basically less than half to almost half of the heart border, you can see over here, as opposed to the thoracic region. In this case, it's actually increased. If you were to take a ruler and measure here and compare it with here, then you can, minus and do the division and see how does it fall to about half or more. And if it's more than half, it's indicative of cardiomegaly. Hence, they present with cardiomegaly, and on the chest x-ray, you see increased cardiothoracic ratio. So apart from that, there is capitalization of vessels. Basically, you can see the vessels more clearly on the chest x-ray, and usually you can see them. There are curly B lines, and curly B lines are indicative of pulmonary edema. And when the edema happens, it usually first spreads through the bronchovascular interstitium and later through the septal interstitium. So it's over here, you can see the curly B lines. And also they will have pleural effusion. And the difference between pleural effusion and pulmonary edema is that the fluid builds up in the pleural space. So this pleural space is basically in between, the space in between the lungs and the chest. So the thing is that for bedsides, or maybe in the exam, they may give a chest x-ray, a little bit about the patient this time of the question, and you suspect it's congestive heart failure, or maybe they may even tell you this patient is suffering from congestive heart failure and a chest x-ray was done. So what do you see? So you explain these 4. Now the treatment. For all patients, and if you want to give them symptomatic relief and to reduce the volume overload, you give diuretics. But that's not the main treatment. Basically, when they come in, they can't breathe, right? As I mentioned over here, ankle edema and paroxysmal nocturnal dyspnea, or maybe sometimes even just straight up edema and shortness of breath. So for symptomatic relief, you first give diuretics, but the proper management would be this. So you start with either ACE inhibitors or beta blocker, 1 drug at a time. And if they're asthmatic, of course, you do not give them beta blocker. And if the symptoms persist, then you add the other one. So if you started with ACE inhibitors, you give beta blocker next in addition. Or if you started with beta blocker, the next one you give ACE inhibitors. And if the symptoms still persist, then you add spironolactone. If the patient were to present with heart failure and atrial fibrillation, then you give digoxin. Now, pulmonary edema, it's often caused by congestive heart failure. And this happens when the heart is unable to pump efficiently. So, in the case of heart failure, the heart is failing. And basically, blood, what happens is if the heart is unable to pump efficiently, the blood may return back into the pulmonary veins and back into the lungs. Basically, heart is unable to pump efficiently, there is backflow of blood. And if there is backflow of blood, eventually the pressure within this blood vessel will rise. And what happens when the pressure rises is that the fluid is pushed into the air spaces, the alveoli in the lungs. So under pressure, basically fluid that comes out of the vessel happens. It comes out of the vessel and it begins to fill up the air spaces, the alveoli over there. So what happens is, this is what happens. What are the clinical features? Patient may present with desaturation, dyspnea, orthopnea, tachycardia, and if you were to auscultate, there would be crepitations. So the investigations that you would perform, first you do a chest x-ray, the most appropriate or initial investigation, you do a chest x-ray, and you would notice interstitial and alveolar edema. And there's also curly lines or curly B lines, plus bat's wing, hilar shadow. Bat's wing hilar shadow is actually this. Okay. And if you were to do an echocardiogram, you would notice left ventricular impairment. So the treatment for this, the mnemonic would be M, O, N, F. M for morphine, O for oxygen, N for nitrates, F for furosemide diuretics. So what you would do is you would sit the patient up, give oxygen first, then you spray 2 puffs of sublingual glycerin trinitrate, and you give furosemide slowly, followed by diamorphine or morphine to relieve the pain, anxiety, and distress. Let's move on to dilated cardiomyopathy. So in cardiomyopathy, all 4 chambers are affected, but the most common one that's, not the most common one, the one that is affected more would be the left ventricle. And there are actually 3 types of cardiomyopathy, but it's for exam, just remember there's 2 types, dilated and hypertrophic. So in dilated cardiomyopathy, basically there's dilatation. The balloon is too big, let's say. So there is decreased ejection fraction and there is decreased septal wall thickness, because just remember dilated, it becomes bigger. So how are you going to pump the blood out? It's like really difficult. So there's reduced ejection fraction, and this happens. Why is it dilated? There's decreased septal wall thickness, as you can see over here. This is a normal heart. Over here you see there's decreased septal wall thickness, and hence it's unable to pump out more, so there is reduced ejection fraction. Now hypertrophic cardiomyopathy, as the name says, hypertrophic, there's increase in thickness or increase in size, hypertrophy. So there is increased ejection fraction because basically the heart tries to pump more and eventually hypertrophy occurs. So basically, you build up the muscle. There is increased ejection fraction, and there's also increased septal wall thickness. You can see there's excessive wall thickening of the cardiac muscles. And the clinical features would be arrhythmias, emboli, mitral regurgitation, and the causes could be alcohol, postpartum, hypertension, or even inherited, autosomal dominant. So the most common cause would usually be alcohol. Next is infective endocarditis. So the moment you read a question and you see murmur and fever, the first thing you think of would be infective endocarditis. So the most common valve affected would be mitral valve. But if the stem includes IV drug users, then it could be tricuspid valve. Of course, in infective endocarditis, all the valves could be involved. Any of the valves can actually be affected, but the most common one would be the mitral valve. And if you're talking about IV drug users, tricuspid valve. So risk factors, previous episode of endocarditis, it's the strongest risk factor. rheumatic valve disease. They may have had rheumatic fever before. Prostatic valves, maybe they're using prostatic valves now, had their valves changed. Congenital heart defects, and IV drug users. So it's really important to know the causative organisms. They would ask this in MCQs as well. So generally, the causal organism would be Staph aureus. But if, let's say, the patient has had a prostatic valve surgery, then most likely it's Staph epidermidis. And if they mention after a dental procedure, then it's Strep viridans. And how would you diagnose this? You would diagnose this through the modified Duke criteria, which I'll explain a little bit more in the following slide. So if the patient presents with 2 major criteria, it is indicative of infective endocarditis, or maybe 1 major, but 3 minor, or 5 minor. So how would you manage this? So first of all, the first line investigation, if you suspect infective endocarditis, like I mentioned before, new murmur and fever, and you suspect it's an infective endocarditis from the modified Duke criteria, you do a blood culture first. The next step would be an echocardiogram, because you want to visualize the heart. Where exactly is it being affected? Okay. So the treatment, if the patient has not undergone any prostatic valve change, prostatic valve surgery, they're still using their native valve, then you give amoxicillin and low-dose gentamicin. But if, let's say, they're allergic to penicillin, then you give vancomycin and low-dose gentamicin. Now, if the patient has undergone prostatic valve change, then you add rifampicin to it. So vancomycin, low-dose gentamicin, and also rifampicin. Let's dive into modified Duke criteria. Major and minor. For major, there are 2 positive blood cultures, and it's very important, not just 1 positive blood culture, you need 2 positive blood cultures more than 12 hours apart, not immediately. Or there is evidence of endocardial involvement. So like if you did an echocardiogram, you actually visualize like, yeah, this part of the heart is actually impaired, and there's new valvular regurgitation. Okay, so that's for major. Now for minor, the patient may have had a predisposing heart condition, like maybe congenital heart defects, or they are a known IV drug user. There is microbiological evidence that does not meet the major criteria. Basically, it's talking about this. A patient presents with positive blood culture, but maybe only once and did not. So that doesn't qualify for major, right? So that's 1 over here. But they may have presented with fever more than 38 degrees Celsius. So this falls under minor as well. They may have vascular phenomena or immunological phenomena. So for vascular phenomena, there are a few, but the important ones to remember here would be splinter hemorrhages and Janeway lesions, because these are what you can see during physical examination. Therefore, you don't have to wait for the blood culture to come back. You can actually just, see from there itself. So Janeway lesions are non-painful, and they are part of vascular phenomenon. For the immunological phenomenon, it's important to remember Osler's nodes, and that's the painful one. And if you were to do a fundoscopy, you would notice rot spots. Okay, so based on the major and minor criteria, that's how you can diagnose. This is the modified Duke criteria. So if the patient presents with 2 major criteria, 1 major and 3 minor, or 5 minor. So it depends on your patient, of course. 2 major, 1 major and 3 minor, or 5 minor. Dissecting aneurysm or aortic dissection, with a little bit on, when it ruptures. AAA. Alright, so it is caused by a tear in the tunica intima of the wall of the aorta. And it is actually injury to the innermost layer of the aorta. And what happens when there's injury over there? This allows the blood to flow in between the layers. So, the blood continues to flow. It's, minding people's business, just continues to flow. So eventually it enters in between the space where there is a tear. And over time, this tear can progress And when it progresses, it forces the layers apart, it will be a very large tear. And this is dangerous because it can lead to death from not enough blood flow, or when there is a rupture, in the case of a ruptured abdominal aortic aneurysm. So when the patient comes in, they may usually present with a sudden onset severe chest pain that radiates to the back. So when you take the patient's history, they come in with chest pain. It can be an MI, it can be a pericarditis. So what is it actually? It can even be dissecting aneurysm. So you ask, does it radiate to the jaw, to the arm? If it does, maybe you're suspecting that it's MI or unstable angina. Is it just over there? Is it relief while leaning forward? Could be pericarditis. Or does it radiate to the back? Or does it feel like a tearing pain? Then you suspect a dissecting aneurysm. And the patient may have unequal pulses in upper limbs. So if you do a physical examination, you'll notice this actually. They may present with hypotension, shortness of breath, tachycardia, and also sweating. You may even ask, is the patient actually having Marfan syndrome, or anybody in their family having Marfan syndrome? So for Marfan syndrome, they're usually tall, long, slender. They have really long, slender limbs and fingers. Or they may even have history of Ehlers-Danlos syndrome or Turner syndrome. So the investigation for this would be a transesophageal echocardiogram, TEE. And you can also do a CT scan with contrast or an MRI. But in the case of an emergency, of course, you can't do all of this. Like the best would be an ultrasound, because you want to see, like, is there a tear? Is there an aneurysm? Like, what is it over there? Why is this patient in shock? So you opt for an ultrasound. But let's say an ultrasound is not available. I'm sure in many hospitals now, ultrasound is like everywhere. But somehow, let's say in the question MCQs, it's not available, then you pick CT scan. And it's important to know this Stanford classification of aortic dissection. Important in the sense that what type of management would you give? So if it's type A, whereby the ascending aorta is affected, which is in 2/3 of most cases, of all the cases, then you would opt for a surgical management. If it's type B, whereby the descending aorta is the one affected, and in descending aorta it's distal to the left subclavian vein, then you opt for conservative management. So that's for dissecting aneurysm or aortic dissection. Now, if it were to rupture, boom. And by the way, if it ruptures, usually, of course, eventually patient will die. But the thing is that the bleeding will occur at the back. And it may take some time because it will start to fill up, and eventually the patient collapses and die. But if they were to present, it would be pain, a triad of pain, hypotension, and pulsatile tender abdominal mass. So when you do physical examination, you would notice there's a pulsatile mass in the abdomen. And clinical features, sudden onset of severe abdominal or lower back or flank pain, or they may even be in shock because it has ruptured. They're losing blood. So they may appear hypotensive, sweating, fainting, and there's absent lower limb pulse. They may even have mottled skin. So it's a surgical emergency. Do not delay. So the most appropriate initial investigation would be ultrasound. But like I said, of course, they just want to play with you in MCQs. If it's not available, you do a CT scan. Okay, so now let's go to falls. And for falls, there are a few differential diagnoses, and these are the most common ones that they like to ask during bedsides, or maybe even in MCQs, or sometimes if you have modified essay question, they would give you a STEM. So which one is it? So the important differential diagnosis of falls to remember would be hypoglycemia, most common cause, of course, seizure, postural hypotension or orthostatic hypotension, and arrhythmias. And by arrhythmias, I'm talking about Stokes-Adam's attack. Okay, so for hypoglycemia, when you take the history, usually the patient may present with sweatiness or dizziness before the episode. So they will come in comatose, of course. And the thing is that they would not wake up until glucose is being administered. Now, if this were due to seizure, you need to have an eyewitness to describe the episode, because they obviously won't remember, like, why did they even fall in the first place. And sometimes when they wake up, they may have post-ictal features. Post-ictal features, basically, it's the features they present upon conscious. So they may appear confused or even drowsy. In the case of postural hypotension, the fall usually follow a standing from sitting. So let's say they're seated very long. Suddenly they just stand up. They may faint or they feel giddy. So the patient would have felt dizziness before the fall. And sometimes they may even have history of difficult mobilization. Now, in the case of Stokes-Adam's attack, usually affecting older people. So the patient will feel hot and flushed after the recovery, and this is due to the sudden collapse into unconsciousness due to disorder of heart rhythm, in which there is a slow or absent pulse, causing the patient to faint with or without convulsions. So basically this happens when the normal heartbeat, usually you have the electrical wave passing from SA node to the AV node. And what happens is, if there's a blockage, the electrical impulse doesn't pass from the SA node to AV node. There's a blockage somewhere. If there is a blockage, if there is an interruption, this will result in heart block. And when the heart block occurs, usually the heart rate will slow down. And when the heart rate slows down, it will cause inadequate blood flow to the brain. And when there is inadequate blood flow to the brain, physiologically, the body will want to cause more blood flow to the brain, because our brain needs blood. This will cause the person to faint, and that's why they faint. It's actually due to this heart block. Not really a heart block, but when the electrical impulse is being interrupted, there's a heart block or a temporary heart block. Maybe the patient may even have a real heart block for all we know. But yeah, that's Stokes-Adam's attack. So what are the investigations you would like to perform? In the case of irregular rhythm, cardiac syncopal events, then you do a 12-lead ECG. Usually it is abrupt, and the moment the patient gets up, there is rapid recovery and flushing, just like in Stokes-Adam's attack. For low blood pressure or postural hypotension, you measure the BP while laying and also 3 minutes after while standing to denote is there any difference in the systolic or the diastolic. Okay. So usually the patient would have had frequent falls or dizziness while trying to stand from sitting position, or they have history of taking multiple medications, polypharmacy, like in most old patients. Of course, there are some young patients who also may have this, but usually among the older generation. If it's a case of hypoglycemia, obviously you want to check the blood glucose. Maybe the patient may have had history of excessive alcohol intake, sweating, tachycardia, hypotension, or confusion before falling. Alright, so if you've reached this part of the video, thank you so much for watching. Do hit the subscribe button and press the notification bell so you don't miss out on any new videos. I post videos weekly, so I'll see you in the next one. Stay tuned.